have it in the lateral position, like that. Because when you do any of the reflexes, there's less of the hand on the body. So if you have it flat like that, there's a chance that you may not see a subtle movement. The other reason for having it lateral is that when you do the brachioradialis reflex, you're looking at the index finger and thumb to see if they do this. Okay, so that's a positive inverted radial sign when you do this, like that, and you see it positive. You've got to control it a bit, because if you go like that, you know, it'll all seem positive. So that's the inverted radial sign. The Hoffman sign is when you just take the middle finger, you control the middle phalanx, and you flick the DIP joint of the middle finger, boom, like that. Okay? And you're looking for the index and thumb again to do this. Yeah? So don't worry if you have it. It's always concerning when the model has it, and then they get really anxious and stuff. But, you didn't have it. 20% of people do have one. Yeah? And when you're anxious, you can get it positive, but also when you're myelopathic. So it's not about picking out individual signs, it's about building the picture. I wouldn't be worried about that in you alone unless your planters there was a problem there, unless you had a positive inverted radial sign, because like I said, the risk factor builds up 20, 40, 60, 80, 90. So that's that. So we've got one left, haven't we? So we know his age, we've done the planters, we've done his inverted radial, we've done Hoffman, that's 4. And the last thing is his gait. And that completes your kind of screen for, is there anything else going on in this chap? You know, obviously in under 40-year-old, it's common sense, we don't need validated studies, it's very uncommon, but it's not. The studies actually show that from the age, literally on that cusp of 40, your risk starts going up of having cervical involvement when you've got lumbar problems. Why is that relevant to you and me? So it's relevant to me greatly, because if someone has cervical cord compression, but they've got a big disc prolapse at L5S1 causing S1 nerve pain, and there's been resistant, and he's failed all other treatments, and I decided to operate on him. If I put him prone on the table, and then when you position their head, you've got to hyperextend their neck, and then you give them a general anesthetic. With the general anesthetic, the blood pressure drops. You've hyperextended him, you've dropped his blood pressure, and he's got cord compression. You're pretty much starving the spinal cord of all oxygen, and they can wake up paralyzed. That's the importance for me. So most paralysis, by the way, is because of hypovolemia. When you hear someone who got operated on who had, woke up paralyzed, it's not because the surgeon dropped his knife in the spinal cord. I've never heard of that. Have you heard of that? Never heard of it. They woke up paralyzed because the oxygen, the blood pressure dropped too far. When we do surgery, we have to keep mean arterial pressure at 90, because if you go under that, we know the incidence of cord ischemia starts going up, especially important in trauma. So if someone has cord compression, and I do a simple L5S1 discectomy through a tiny wound like that, make no muscle, minimal muscle, loss, and I relieve the pressure on the nerve, you could wake up paralyzed from the hyperextension and the hypovolemia from the lower blood pressure. From your point of view, it's very important, because you do not want to do I've talked about thoracic rotation, stiffness, and techniques you would use for your rehab. Now, if they have cord compression at 1, 2, 3 levels, you're not going to want to do too much to that person, and that's important to recognise. So that's why it's important. So I don't know if I've mentioned it. I've mentioned it all day long, but I have normally around 3 or 4 private patients a year who come to me referred with low back issues, where I end up operating on the back of the neck, and often they don't have neck pain, or they've had a bit of stiffness. In the NHS, like I said, it happens quite often, so it's something to look out for. So I'm just emphasising not the things you see day to day, which you're all very good at, otherwise you wouldn't be, professional clinicians, but the things that I see slip through the net, and that's certainly one of them. And in terms, obviously, that we have one left, which is gait. If you could stand up for us. And all I do, very simple screening. Often, if someone has clear myelopathy, you will know it before they've sat down, because they'll walk in, and you will read the history from someone who sent it to you, and they'll walk in, and you'll see a kind of broad-based gait where they're struggling with their balance and they can't turn around, and everyone thinks it's antalgic, but actually either because it's worsening or because it's obvious. You see them walking from the sitting room, you can tell. But what I normally do is if you can walk normally to that wall there. Okay, and turn around, and then what I get, no, hang on. If you can now walk like you're walking on a tightrope, like that. That's it. Okay, just relax there. So beware of the person who has a scoliosis, okay? Because remember they have pelvic tilt. Okay, so when you have someone who's got pelvic tilt, who then does walks on a tightrope, the heel-toe test, they won't be doing it like this. They'll be doing it a bit like, unless they've got great core control, they'll be like this because their pelvis is tilted. So just beware of that false positive. You were doing that a little bit just now. You see how you need to get one of these guys to help you with your core. So you were doing a little bit of that. That's why I paused when you were doing it. You were just coming off your balance a bit because your pelvis is tilted. You see how he stands? You certainly got you naturally stand with one leg slightly bent, do you? Yeah. So the gait, that's the last bit, the last of the 5 things. So I've not covered everything because I couldn't even cover half of it with the time I was given. But what I've tried to do is pick out some things that either aren't focused on enough, I'm not saying you don't, but in general, or that is the things that slip through the net that you need to be more aware of. So anyone with a mild structural coronal plane deformity, so a scoliosis, always examine everything, all the reflexes I showed you. Always consider rotational stiffness, which I know you're all good at, especially the osteopaths. And Carios are very good at picking that up. And in terms of the patient who's resistant to treatment, again, think about those 5 factors that we talked about. Because if you think all the patients that I've seen who've failed lower back treatment or got worse and have had cervical involvement, if you look back at their notes, and it's easy in the NHS because you've got it all in one thing, you'll notice that actually they haven't been tested by everybody, SHO, physio, GP, registrar, and it's just a catalogue. And it's not a once-a-year occurrence. It's a very common occurrence, and like I said, I see it quite a lot as well. Anyone got any questions?